Salam sir. Abdul sir, assalamu alaikum. Salam sir. হ্যাঁ দেখছি please. Assalamu alaikum. Good evening. Welcome everybody to today's Cathlab Series-5. Especially Professor Dr. Abdul sir and our respected faculties, Dr. Shams Manwar, Professor Chowdhury Meskat Ahmed, Dr. Khaled Mohsin, Dr. Timir Ahmed, Professor Timir Ahmed, Professor Waliul Islam, Dr. Kaisar. Also, lots of faculties are waiting. I think they are busy with schedule in the Cathlabs. Also, I think they will join. And I welcome Dr. Timir Paul. I really grateful IPDI. You manage your time, the busy schedule. Today's talk. We have note Dr. Timir is in Bangladeshi physician, but he is already renowned physician in the USA. Welcome Dr. Timir Paul to this session. And today's another speaker, Dr. Professor Waliul Islam. I will also welcome you to this session. Today's are two topics. One topic is the selection of catheter and guiding catheter and diagnostic catheter. We'll talk by Dr. Waliul Islam. And another is the balloon design and selection of balloon in the Cathlabs. So, Professor, I am requesting Professor Abdul sir, please opening remarks and start the session.
Assalamualaikum everybody, and a very good evening. And to Timir, good morning. And this is really a pleasure to welcome everyone to the session, our IPDI Cathlab manual series number 5. And today we'll be talking about one of the basic things, because when we are talking about diagnostic and guiding catheter or the balloons, these are actually the platform on which you stand and proceed to solve difficult situations, difficult problems. Unless you have clear idea what sort of guiding catheter, what sort of wire you are going to use, there will be a lots of problem, particularly when you are dealing with CTO or completely calcified cases or complex lesion or bifurcations, everything like that. So today's topic are very important and pertinent, particularly for the young budding cardiologist. I think all of us are going to enjoy the sessions, and welcome to our speakers.
I'm requesting you, Professor Dr. Waliul Islam, please start your talk and share your screen. Dr. Waliul Islam. Should I start?
Well, if I should, you should
Sure, go ahead.
आपका share screen दिए थे.
Assalamu alaikum and very fine good evening. Honorable President Professor Abdul Chowdhury and Dr. Mohsin, Secretary General of IPDI, for giving me an opportunity to say something about guide catheter and some diagnostic catheter in this excellent IPDI meeting. So we all knew that there is a basic difference between diagnostic and guide catheter. Diagnostic catheter is 2-layered and guide catheter is 3-layered, and it's braided with steel, and it is diagnostic comes in 5 and 6 friends, and PCI comes in different format 5, 6, 7 size, and guide catheter is having tips, primary curve, and secondary curve. Guide catheter is a stiffer shaft, larger internal diameter, and shorter, more angulated, and reinforced construction. It's a 3x2 layer. And this, we all knew that pigtail, it is having multiple catheter, it's rounded shape, it's not selectively, no selective calibration is not needed, and contrast injection through multiple sites. So it can be used for ventriculography or aortic root graphy to see the arterial origins in different positions. And diagnostic catheter is selectively cannulation of each vessel, rotational stiffness enough to selectively seek a vessel orifice, enough flexibility to advance into vessel. Flow rate not important as contrast volume. So this is for the coronary angiogram catheter. Regarding coronary angiogram, much has been said by previous distinguished panelists and speakers. So I will say some things, very small amounts, small on angiographic catheter. So this is all we know that these are the different catheters available: Tiger, Jackie, Amplas, and Judkins left, right, and Lima catheter. Diagnostic catheter for femoral root, we can use Judkins left, right, and Amplas left, right. Multi-purpose we can use, and for transradial, transulnar, distal radial approach, we are using commonly in our country, that is Tiger. So Tiger catheter, the advantage is it can be cannulated in both LCA and RCA at the same time, so without exchanging the catheter, shortening the procedure and fluoroscoping time as well, and lower cost per procedure. And it has side holes, so avoids intimal dissection during injection in non-coaxial engagement, prevents kicking off during injections, available in 5 and 6 prints. So utility of guide catheter, a good choice of guide catheter makes the subsequent procedure simple without the need to resort to complicated hardware that exposes the patient to unnecessary risk. And this slide shows important features of a guide catheter. It has outer jackets, Stainless is still braided in between the inner and outer layer. Inner layer is lubricious and it has device compatibility, larger lumen, and outer jacket provides strength support, kink resistance, and flexibility. Functions of a guide catheter. It acts as a conduit for injecting contrast, transporting guide wires and devices for measuring aortic and arterial pressures, system for backup support during interventions, balance between support and vessel damage from aggressive intubation. So before going for any interventional procedure, we need to consider the following things: diagnostic curve selection, size of the aortic root, origin and takeoff of target artery, lesion severity, device to be utilized during intervention. So if we can plan before proceed to the procedure, then our next several minutes to hours will be comfortable for us as well as for the patients. Certain points to remember while using guide catheter: aspirate vigorously as atheroma or thrombus is scooped up from the aorta. Insist on bleed back, prevent air embolus, avoid blood standing in guide, flush frequently. Proximal or ostial disease, avoid amplas, cared with side hose and deep engagement. This we all knew that these are the several routes commonly using: femoral radial, ulnar distal radial. And exercise site issues is tortuosity, surgical graft, scar tissue, diseased iliac, name loss. Most commonly used guide catheter is 6 to 7 French catheter, and small guides require backup curves for added support. Large guide require side holes to improve perfusion. And French size influence: 6 French guide pros is small arterial puncture, brachial radial, ulnar distal radial route can be used, permit active support, less contrast, and cons is smaller internal lumen, less visualization. 7 and 8 French guide catheter, better passive support, it offer better visualization, better torque transmission, and the cons is larger arterial puncture may need, especially for old age peoples and elderly ladies. If you go through femoral, then it will be chances of hematoma for big puncture for these sheaths and guide catheters. Pressure dumping might happen and more contrast is needed. As we all knew that 1 French equal to 0.13 inches, and that is 0.33 millimeter. Guide catheter has thinner wall than the diagnostic, and repeated spinning makes weakens and ruin the procedure, and rotate it while advancing or withdrawing it, maintaining wire within the catheter. Deep inspiration may help in placing the guide catheter. If no torque control, long sheath, especially in case of long tortuous iliac vessel, iliac artery through femoral root, it is needed. While doing procedure, we all need to keep continuous monitoring on the regarding pressure dampening, because it might happen so ventricularization of both pressure systolic and diastolic may damp due to tight ostial lesion, spasm, non-coaxial alignment, or mismatch between the guide and arterial lumen. And this can be avoided by side hose, but side hose allow perfusion but do not prevent guiding catheter injury to the ostium. So while doing the procedure, it's always we in our practice routinely we try to do the non-selective injection to see how the ostium is looking like. So then we proceed by engaging the ostium. And we all knew these are the most common catheters available in our country, and most of the cath lab in Bangladesh are using this this guiding catheter: Judkins, Amplas guide, multi-purpose, and extra backup. Regarding Judkins catheter, as primary curve is fixed, may not be coaxial with the artery, and may be difficult to pass balloon as catheter makes 90-degree angles with the ostium. JL point of contact on ascending aorta very high, and narrow causes increased chances of prolapse and dislodgement. And Judkins right, no point of contact on ascending aorta, extremely poor support. And this is the PCI we have done through femoral approach by using Judkins left 3.5, 7 French. And this one on the left side is the diagnostic left main, and on the right, by using 7 French Judkins left, this is the left main to LAD PCI. And this one is Judkins left 3.56 French LM LAD through femoral approach. And this is the cine on the right side, LM, LAD, PCI. And this one, Judkins right, 3.56 friends. And this is mid-RC. Recently we have done, actually this case was done by Dr. Shams Munwar and I was assisting him. And this is very difficult to cross the lesion. So we use took Caravel, and with the guide gel support, finally, eventually we capable to place the stent. So as I said, that Judkins right is not providing good support, so it's no backup support from Judkins right. And Judkins left 3.57 friends femoral root, left main PCI, LAD, and L6 by kissing technique on the left hand side. This is the diagnostic angiogram. On the right hand side, this is the after the procedure. M+ guide, it was diagnosed, it was originally catheter by Kurz M+, an Australian radiologist in 1967. So it comes in left and right. It has three sizes, 1, 2, 3, increasing curvature, and 0.75 size and increments of 0.5 and size also available for M+ left. It has a primary curve and secondary curve as well. So we must be very careful about while we are using M+ guide catheter. It comes usually in size 1 is for a small caliber aortic root, size 2 is normal, and size 3 is large roots. And we all knew that, especially in the subcontinent, the aorta is, we are short stretcher, our aorta is short, and also curvature is very short. So most of the times we are using very short profile catheter, 3, 3.5, and sometimes we need 4 size or 4 size. We always, it's always needed not to force, not to do any force engagement for guide catheter engagement, especially M+. If guide catheter is too small, if the tip does not reach the ostium and keep lying below it, then it is too small, and if it lies above the ostium, guide is too large. When RCA ostium is very high, left M+ guide may be used to engage the right ostium, as it will come in the next scene. So secondary curve rest, again on non-coronary posterior aortic cuffs, offer firm platform for device advancement, best in case of short left main with downgoing left circumflex artery. Tip point slightly downwards, higher danger of osteal injury causing dissection. And this is the procedure we did by radial, via radial approach by M+ left 1/6 French guide catheter. You see on the left side the diagnostic, and this is the scene, and this is the final scene. And next one by mid-RCA lesion, femoral approach via M+ left 1. It's a CTO lesion, fine cross the lesion, and then we did the PCI. This is final scene. And we must remember that withdrawing of M+ should be very careful. Otherwise, while disengaging, it can cause dissection. So to disengage first, advanced guide slightly to prolapse the tip out of ostium, then rotate so the tip is totally out of the ostium before withdrawing it. After deflation, if balloon is pulled out, the M+ tip for any guide would have the tendency to be sucked in deeper. To avoid this, pull the balloon out while simultaneously pushing the guide in to prolapse the guide out. And this is one of the most fabulous and workhorse guide catheter, extra support. It comes in EBU and XB both form, and it provides broad secondary curve braces against the contralateral wall of superior backup. Provides for superior backup, and it comes in different sizes as it shows in picture. And this procedure, osteoproximal LAD via femoral root 6 French 3.5 EBU. On the left panel, the diagnostic catheter, diagnostic angiogram, then the balloon inflation, and this is final scene after stent deployment. And this is proximal LAD by EBU 3.5 5 French radial approach. This is final scene. And this slide shows the bypass graft cuffs. Usually we, in our common practices, is using right Judkins catheter for diagnostic angiogram of SVG grafts and Lima as well, and sometimes Lima we can use, we are using. And this PCI we did post-CVG patient via femoral approach, RSVG to RCA. This is the lesion. Then stent deploying, and this one the stent after deployment. And this is post CABG. We use 7 XB 3.5 femoral root. Left side shows the LMLA dilation, and then this is after PCI. This is showing radial approach, and nowadays most of the centers are practicing and doing most of the PCI left via radial approach. So common uses catheter for left transradial approach. Judkins left, it provides suboptimal support for PCI. So consider for proximal lesion and downsize secondary curve by 0.5 centimeter. And workhorse catheter is extra backup, XB or EBU, and a good backup from contralateral aortic wall or sinus of Valsalva. And plus left passive support, deep engagement, complex PCI. On the right panel, it shows transradial PCI of the right coronary artery. So Judkins, it provides support as it is similar as transcranial, but with backup support as it does not contact the contralateral aortic wall. And plus right AR1, this provides some passive but no active support. But M plus this is a really a good guide catheter, and it provides passive support, but fits well in Shepherd-Crookes configuration, but higher risk of coronary dissection. And this actually this about this Lima cannulation, it has been discussed by previous speaker in this IPDI excellence session. So I'm not going too deep in this one. We all knew that coronary anatomy osteal variation is maybe location high, low, anterior, posterior, and orientation may be superior, horizontal, inferior, and Shepherd-Crookes. And as you see on this figure 1, right coronary normal position, 2 anterior, 3 posterior, and 4 is left coronary normal position, and 5 is high and anterior. And this is this figure shows the curved length of guide catheter, the distance from the primary and secondary curve. Curve length consideration: shorter curve may be useful for vessel with superior orientation, and longer curve may be useful for vessel with inferior orientation. And catheter size to aorta, the lower picture shows this proper fit catheter, Judkins left, and it's a 45-degree angle at the primary curve. And the other two shows it's not proper fit. One is too short, other is too long. And coronary ostium take-ups, as we all knew that horizontal, it may be inferior, superior, and coronary osteal origin may be very high and up. And this picture shows on the left panel, right coronary horizontal origin, inferior, superior angiogram. On the right panel, left coronary artery, horizontal, inferior, and superior. Selection of guide catheter is very important. Proper size catheter, coaxial intubation, adequate guiding support. 5 frames, 6 frames, 7 frames, 8 frames, 5 frames, and 6 frames we commonly used nowadays by radial access, and so we can take a drug-eluting balloon, scope balloon, stents, rotabar by both, and even 6 frames guide catheter we can do kissing stenting if we want. IFAS catheter also taken with this one, and 7 frames simultaneous rapid exchange balloons, bifurcation stenting requiring double stenting, crash, stenting, thrombustor, 1.7 rotabar. We commonly use this for femoral approach. Coaxial alignment is the key. Guide catheter on the right panel, you see the two figure, coaxial and non-coaxial, and guide catheter selection, coaxial alignment is for complex anatomy. The lesion is difficult and tortuous. It is tortuous and need for extra support. If yes, then we can select extra support guide. Support from opposite wall of the aorta, so that can be provided by M+, and support guide support from sinus of Valsalva, and this is also by M+ in case of right coronary. Guiding catheter selection and support. Standard guide for most of the patients, minimal support catheter reside above barely in sinus of Valsalva, the Judkins left, right, and LCB or CB. Support derived from sinus of Valsalva catheters reside deep in ipsilateral sinus of Valsalva, M+ light, left, right, hockey stick, L-gamma champ, and MP, multipurpose. Power guides, extra support, maximum support derived from opposite wall of the aorta, Boda, XB, EBU, and Arani. As we see on the right panel picture, this the first one, simple coaxial alignment without support, Judkins right provided hockey stick. It's provide coaxial alignments with extra support from sinus of Valsalva, and on the right panel coaxial alignment with power support from opposite wall of the aorta by EPU. Guide selection left, size of the curve depends on aortic root diameter. This picture on the left panel, this is the normal diameter, root diameter, dilated root, the size will increase, and superior origin M+, and then short left when we can take Judkins left. How to select the curve? Left coronary artery length variation, as you see in this picture, there is short left main, long left main, and there is separate origin of LAD and LCX. So smaller guides will selectively engage in LAD, larger guides will selectively engage and give better support LCX, and plus tips selectively engage LCX. Guiding catheter selection, high takeoff, left coronary artery, M+ or extra backup, abrupt downward origin of circumflex, larger M+ or extra backup. Properly sized left extra backup coronary catheter on the left panel and right panel left M+ guide catheter associated with increased complication. Guide catheter selection for right, the left panel Judkins right, then inferior orientation modified right M+. Inferior orientation we can use multi-purpose as well. Anterior origin right cast multi-purpose. Guide catheter selection RCA Shepherd-Crooks Arani or Champ, and superior origin Mac Champ multi-purpose dilated root left M+. Possible solution to difficult right coronary guide catheter selection. We all knew that guide catheter, especially right coronary is the single coronary artery that is having most common anomalies than left coronary artery. So this picture shows the usage of different catheters in different origin of right coronary. This one also shows uses of different coronary origin of RC and different guide catheter. Right inferior takeoff Judkins right on the left panel, and also multi-purpose we can use, and Shepherd-Crooks right side Shepherd-Crook catheter, and we can use M+ as well. And bypass graft, there is dedicated bypass graft catheter, but we are commonly using right Judkins for most of the venous graft angiography, and some instances also for Lima, but Lima catheter also using for Lima angiography. On the right panel, first one is left vein graft, then right vein graft, and internal mammary artery visualization by angiogram. RCA graft is your location primary alternate Judkins right M+. RCA graft is your location primary M+, alternate Judkins right. LCA graft primary Judkins right, hockey stick, alternate M+ left, multi-purpose. LCA graft anterior location primary M+ left HS, and alternate Judkins right. Actually, there are so many guide catheter and so many methods and so many ways are engaging, but we should be very comfortable, and we should make our life by using the simple method and simple guide catheters. And we all knew this is the anastomosis side. On the left side, there is SVG to RC and SVG to LAD, and Lima, RIMA both side, and on the right side, the horizontal. If it is horizontal position, then it is Judkins right, M+ right, multi-purpose M+ left, or superior hockey stick, LCB, MP. And SVG to RCA or LPDA horizontal is Judkins right, M+ right, left, multi-purpose, inferior multi-purpose, M+ left, M+ right. And this figure shows catheter selection for saphenous vein grafts, multi-purpose or right Judkins hockey stick, or M+ left, or hockey sticks. While doing the interventional procedure, we need to be careful or follow up this, keeping in mind these are the complication might happen while we are doing the procedure. So atherembolus, it may be unrelenting ischemia after injection, slow flow in recipient vessel, associated condition, calcified aorta, abdominal aortic atherosclerosis or aneurysm, peripheral vascular disease, and treatment is supportive treatment of ischemia. Air embolism also one of the important complication can happen. Clinical features: acute ischemia after coronary injection, transient symptoms, associated condition, large diameter catheters, no bleed back air visible in coronary. Treatment is support circulation, aspirate air, coronary injection. Thromboembolus also causing acute ischemia, vessel cutoff, associated condition, multiple catheter exchanges, prolonged procedure, suboptimal anticoagulation. Treatment: thrombectomy, thrombolysis, balloon fragmentation. Left main dissection, this is really the most nightmare causing this while doing procedure. If anything happened, clinical feature is angiographic evidence of dissection, ischemia, and hemodynamic collapse. Associated conditions: left main disease, amplas catheter, difficult coronary intubation or balloon or stent withdrawal, poor fluoroscopic visualization. Treatment is CABG or emergency stent. Iatrogenic dissection, rare complications secondary to guide catheter trauma, injection of wedge catheter or balloon rupture. Class 1 limited to coronary cast, class 2 limited to cast proximal aorta, and class 3 is extending to aortic arch. While advancing catheter through the tortuous iliac artery, we should be careful in rotation with constant watch. Can twist or king, use long sheath, insert 0.38 inches wire through wire after guide. Tip can be manipulated near ostium. Remove stiff wire, flash guide, engage tip to the ostium. Manipulation to enter left main ostium, gentle push, pull, counterclockwise torque. Visualized by gentle injection, ostium can be seen. If left main above the guide tip, a pull back and repeat the torque. If anterior to the tip, a gentle counter torque or twist anteriorly. For posterior, a small clockwise torque to guide tip posteriorly. Coaxial guide alignment is also very important for stent, cutting balloon, directional, rotational, ablative, thrombectomy, distal protection devices, as these are rigid and large profile. And non-coaxial alignment may lead to injury, endothelial denudation, leading to thrombus or ostial dissection. Tips for anomalous coronary origin. There are several catheter has been tips, so make everyone's comfortable and use accordingly. Whatever guide catheter can easily engage and cine can be taken. Missing coronary, in this case, we can do the aortography in LAO RO projection. Stabilizing guide with body wire, anchoring balloon with long sheath, extend tip of guide 6 French AL inside 5 French multipurpose. Strengthening guide 6 French AL, 5 French heart rail can sit deep into artery, mother and child. Guide liner, a flexible cath, as we have shown one of the scene we did in this in the previous slide. So take home message, Mr. President, Secretary, distinguished panelists, respectable teachers and learned audiences and respectable colleagues. Proper size selection of guide catheter, over the wire advancement of guide catheter, observed by fluoroscopy if any resistance in advancing guide. Keep watching any pressure dampening, especially in endolithic tortuosity with diffuse disease, iliac artery, use long femoral sheath. Radial advancement, severe spasm can be overcome by cocktail of verapamil and nitroglycerin change or downsize catheter. Diluted heparin may not cause burning or spasm. Preloaded with midazolam 0.5 milligram, 1 tablet at pre-night and 1 milligram IV before procedure, as we do commonly in our daily practice, makes comfort for both patients and operator. Keep watching any hematoma through, if it is through femoral root, any swelling, if it is forearm in radial. Think positive with available resources. Thank you very much. Thank you for your patience hearing. Stay safe, stay COVID-free.
Thank you, Dr. AHM Waliul Islam, for a nice, elaborate presentation. Thank you. I think you touch every aspect of guide catheter and diagnostic catheter. Professor Abdul Chowdhury, sir.
Sure. I would like to thank Walify because he knows that these lectures will be preserved in the YouTube. So the young fellows, if they want to clarify a point or more, they can always go there and look through the slides and can find out the answers for a particular problem. And Walify is taking enough care and ensure that all these sort of problems can be answered through his lecture. Thank you, Wali Bhai.
Professor Chowdhury Meskat, sir. Professor Chowdhury Meskat, sir.
Thank you very much for asking me. It has been a very elaborated demonstration of the diagnostic and the interventional catheters, but I would like to see the more commonly used catheters rather than using the name of whole areas of catheter. That would rather help us in finding out among our armament, common armament, which one can we use. To me, as an interventionist, I always found the my difficult portion of my whole intervention is in engaging the ostium by the diagnostic or the interventional catheter. It has always been a difficult problem for me. So I always wanted to know about the proper selection of the proper catheter for engaging. So detailed anatomy of the aortic root, detailed anatomy of the position of the ostium, and the different curve of the different catheter as could be demonstrated graphically for each catheter, and that would have helped us more, I think. In any case, as Professor Wadud said, that if we recapitulate and if we rewind the whole lecture, which will be preserved in the YouTube, then probably we'll be able to find out the proper answer. Thank you.
Thank you. Guide catheter is the most important part of the intervention. So we should know our hardwares first. So, Professor Abdul, sir, do you hear me?
Can I add something?
Yes, sir. Yes.
When engaging a catheter or manipulating it, we should have a look at the pressure profile, pressure wave profile. If you ever find the pressure wave is not there, that means we have already kinked the catheter or make a twist in it. So do not proceed further, untwist it and ensure that you are changing it for a better catheter. And before proceeding, just have a look at the chest X-ray if available. The size of the aorta will guide you whether you are going for a 3.5 or 4 size catheter. Simple thing, but that helps. And if you're going for an elective procedure, PCI, if you get a good look at the coronaries, for a short left main, a gel will provide better engagement and ensure that you are not going to traumatize it. Whether if you are going to use a plus or a ABO in a short left main, there is much more chances of injuring the ostium or a dissection creating havoc for you. And these are simple things, but these are very helpful. But again, if the left main is quite long, and if you are using a gel, you are in trouble. Your catheter is not going to provide you any support. Then ABO is the good choice, or gel, something like that. These things always help. Simple, but always pertinent.
Rightly said, sir. Professor Abdul, sir, do you hear me, sir? Sir, your experience, because you're the most experienced intervention in Bangladesh, sir, you share your experience in the cath lab, because guide catheter is the first important part of the coronary intervention. If you do not engage the catheter, you do not anything. Sir. Professor Abdul, sir. Please unmute yourself, sir.
Unmute, sir. Abdul, sir, unmute, please, yourself.
স্যার ওখানে সমস্যা হচ্ছে বোধহয়
Abdul, sir, do you hear us?
হ্যাঁ এটা শুনতেছে কিন্তু স্যার আপনি কি বেরিয়ে আসবেন স্যার আবার Dr. Khaled Mohsin, sir, do you hear me, sir?
Yes. Thank you, Dr. Wali, for very nice and elaborate presentation, and it will guide our young interventionists to what catheter to select and use it in an effective and safe manner. One point I would like to emphasize that we are using the ETO catheters, many of the instances, but when we are doing the ETO catheter, we must keep in mind that the shape becomes a bit altered when we are using the ETO catheter. And when you are using the ETO catheter, we might need to select a one size smaller catheter for coaxial engagement of the catheter. So if you are using a new catheter and a ETO catheter, there will be some difference in the selection process. And when we are using a ETO guiding catheter, we must keep in mind that the tip of a ETO catheter becomes more harder, and it might be it is prone to cause more osteal injury in compared to the new catheter. So we should keep in mind, and we should always watching the tip of the catheter when we are putting something inside and putting things outside of the coronary artery. Without a fluoroscopic guidance, we should not, you should always keep the tip under surveillance, because the tip of the catheter is causing the most of the mischiefs. So it is my advice to the junior colleagues. And in some instances, we need to shorten the catheter sometimes manually. When we are using a retrograde CTO intervention, we need to cut the catheter manually and shorten it. And in some cases, we need to have an extra length of catheter if we are doing the infrarenal intervention from the radial route. So we have to do, we have to keep in mind the required length in these situations. So thank you, Wali, again for your very nice presentation. Thank you.
Dr. Khaled Mohsin, sir, I have a question to you, sir.
Yeah.
In case of right catheter engagement, usually all the fellows are difficult in the right catheter engagement. So beside the Judkins catheter or Tiger catheter, you should have some catheter in the cathlabs. What catheter you suggest in the cathlabs, and in position which you commonly use in the cathlab?
Actually, unfortunately, in most of our cath labs, we don't have a luxury of too many variety of catheters actually. So I think the interventionist, apart from being conversant with the right coronary Judkins catheter, they should be able to use the M+ catheter. M+ left is a very good catheter, but we don't have the versatile length. Sometimes M+ left is a very good for CTO intervention or difficult right coronary cases. And one of the catheter which was it is not available in our country, but some of them in the radial route, the Ikari catheters are very good. Ikari is a very good for radial route intervention. And another is a 3D catheter, 3D for the right, because the right support is the main problem in complex intervention. So the interventionist should be aware of the limitations and as well as the variety of catheters needed in this group of patients.
Thank you, sir. Professor Abdul, sir, I think you unmute. Professor Abdul, sir.
Yes, no, thank you very much. And thank you, Oli, for your presentation. I think so today's lecture is that the catheter selection. So catheter, we are using the catheter in the reuse catheter. That's very important. So most important thing is that in the reuse catheter, the catheter maybe breaks inside the body. That's very important. So we have to be careful about that. And everybody said about that the more you sterilize it, the harder will be the catheter tip, and the more the catheter will be breakable. So be careful about that to avoid the twisting of the catheter. And always when you pushing the catheter, and pressure should be on board, so that when there is a pressure is not seen, that catheter might be either kinking or it is blocked. That's very important. And nowadays, the Judkins catheter are so fine that it automatically goes to the left side and right side. But problem is arising when the catheter is anomalous origin. Suppose sometimes the right coronary arising from the left side, left coronary sinus. In that case, left Judkins is a better catheter. Or if you want to do the PCI, then you can use the left gel 3.5 or like that. But in the RCA, sometimes we need a multi-purpose, we need an M+ catheter. But for using, we have to be careful about that. So one question is raising that to make the side hole of the catheter. But when you make the side hole by putting the needle that you have inside on the table, but the the needle prick should not be on the same line. It should be above or down. It should not same line. So if it is same line, then the strength will be less and the catheter will break. So if we put one line at the level and then you go up one level up and another, so that you can 3 or 4 like that. But please don't do that on the same line. That's very important. Otherwise, fine, excellent. So thank you, Ali, and thank you, organizer, for arranging such a simple but very important lecture. This is basic. This is very important for the beginners or papers. So thank you very much. Thank you, everyone.
Thank you, sir.
I have one.
Ashok Datta,
Yes, sir.
any question from you?
Abdul sir, thank you. Oliver, thank you. That's a great lecture. But too many catheter you have mentioned, it is difficult to get all the catheters. And regarding Ikari catheter, Khaled Mohsin sir, we have got Ikari catheter, and sometimes we use it, though it does not give good support. Mathematically, that is very good supportive catheter, but actually in clinical practice, I have seen that is not a good that is not good supportive catheter. But sometimes that may be helpful. We have got Ikari in our Cathlab. And Abdul sir was telling 2 or 3 side hole, and during side hole, definitively should be within the catheter. Number 1, so good flush should be given. Should be third. That is very important. To pull the regular wire so that inner surface get smoother. Otherwise, when the balloon or stent will go, that may be that maybe that is lost when it crosses the side of hole. That is, if we made it manually. So that hole should be perfect. Number 1, inner side of the hole should be made smoother.
Thank you. Thank you. Professor Mohsin, sir, do you hear me, sir? Professor Mohsin, sir, you have the vast of experience, sir. Catheter use in the Cathlab, sir.
Nice
Please
to
share
see
your
all this.
Hello, sir. Yes, sir.
Thank you, thank you. Nice to see all this face. Thank you, Wadud and Mohsin, once again to organize this thing at least once in a week or twice in a week. You used to see all this beautiful face. Yeah, well, thank you, Oli. It's a wonderful lecture for the juniors or budding interventionists who can get much knowledge about his lecture. And also I thank the other panelists who discuss something related to this lecture that also enrich the total tips and tricks of choosing guide catheter and guide diagnostic catheter. Sorry, I was absent in the first part. So far, I got the lecture from the guiding catheter. In general, rightly said by Ashok and Mohsin, that you don't need too many catheters. Say, personally, I feel commonly, and almost, I should say 98% cases, for right coronary artery, I think Judkins is very good. Sometimes you need a hockey stick catheter, especially in Shepard's-Cook type, and AL1 and high up, and also multi-purpose. These 4 catheter is enough to hook almost 98% patient with right coronary intervention. And regarding the left coronary, I think Judkins definitely, EBU, although Judkins is not give enough support, but EBU, and rarely you can use M+ catheter. Be careful about handling M+ catheter. And while the guiding catheter for graft vessel, I think for the right side, multi-purpose is good enough. For the left side, you can use left bypass graft or M+. And because of the common use of radial access for the nowadays for the intervention, you must be very careful in handling the catheter, because if you manipulate too much, then there is a chance of spasm, then whole game will be mess up. So it must be very gentle in handling the uh, uh, guide catheter, especially in radial artery. You may use a wire, 3-5 wire within the catheter for better torque control and with minimize the manipulation. Sometimes you may fail to engage guiding catheter properly. In that case, you can use a diagnostic catheter to hook the coronary, pass the wire, exchange with the guiding catheter. There is a good method. If none make you success to cannulate the right coronaries, and you must be very careful about the, as Abdul said, we are using reusable item, but it should be a limit. But the standard one is for the diagnostic one, you should not use it more than 3 times because it is so cheap. Why to use these things repeatedly? And it increases your effort, increases your radiation. So it's better to use diagnostic 3 times and guiding catheter. At best, you can use it 5 times. And because of the ETO, it's not only it change the shape, it also there are so many things like kinking or compress. So while using the guiding catheter, you just take the guiding catheter, make a just tactile feeling from top to bottom. That is there uh, any kinking or any what it called change the shape at the body of the catheter. Sometimes because of the pressure, it may slit like, so it is very difficult to cross with a balloon and anything. So before entering the system, you must check it once. There's a good practice to make a habit, and I think there's excellent program, and this is very helpful for the junior. And I'm really delighted to see this program, and also interested to still I'm getting knowledge from this, uh, because everybody has got their unique practice, may come across many things that actually I didn't have their experience. So this is a good platform to learn, not for the fellows, for everybody. Thank you once again,
Everybody.
Mohsin and Wadud, and also all the panelists who are contributing and exchanging their knowledge, enriching their knowledge, so we can make the product both for the patient and for the us. Thank you once again.
Thank you, sir. Professor Bijawaluddin, sir. Professor Bijawaluddin, sir. Sir, for the radial, sir. Radial intermittent guiding catheter, sir.
Thank you, Professor Wadud and Dr. Mohsin for arranging this program regularly. And practically on Friday evening or night, usually we remain idle in the room, in the homes setting. So it is very important and very interesting that they have decided only on the Friday this program, and which helps us that we can participate.
Yes.
Thank you. And Professor Wali, you have described very nicely. I have seen your lecture, previous one I did not enter to enter. And so I have so amazed to see the different things which we can do repeatedly and in our practical life. And regarding the guide catheter, Mohammed John Bhai has already told several things, and the other panelists also told. And one thing I want to add, that guide catheter non-coaxial or guide catheter not at all able to engage the vessel. How shall we do or overcome this this way? In the if I do a left main PCI and I see that 99%, 90%, 95% stenosis in the left main, I can't enter into the left main. Whenever I enter the left main, then there is a fall of blood pressure. And it is very dangerous situation. And so in that case, what we do, that we keep the guide catheter almost aligned to the origin of the left main and keeping outside the vessel, outside the coronary artery, we enter the guide wire. And it is a technique, and most of us you are doing and we are doing, but to know, but to tell about this, that we can do in this way. And this way, whenever wire is crossed, then depending on the wire, your guide can be engaged. And this may be for critical ostial stenosis, or sometimes due to abnormal position, guide catheter could not be negotiated appropriately. In that case, we can also do it, keeping the guide catheter outside the ostium and doing the procedure. And besides this, regarding the radial route, I think it is almost same pathway. Pathway is different. One is going from above and one is going from below. And the pathway is different for this, but most of the techniques are same. And particularly what I like, my very small experience in this field, I like that for the left guide, for the left system guide catheter, mostly extra backup guide catheter, and sometimes I use Judkins left also. And M plus, according to Dr. N.M. Mohamed, who has told just now, I also afraid of M plus catheter, and as far as possible, I do not use M plus catheter. Mostly extra backup catheter for the left system of different curve according to the origin of the vessel. And there is another thing, probably someone has told also, that if the origin of the left main is downward or upward, if it looks downward, then catheter size will be above. That is 3. If regularly we use 3, then in this case we shall have to use when the origin is upward directed, then down curve, and when the origin is downward directed, then up curve of the catheter is used routinely. And for the right, mostly Judkins right is all right, and in some cases we also use the M plus catheters. And for the left system and right system by the same catheter, this is my usual practice. If possible, if there is angioplasty of one patient of left coronary system as well as right coronary system, then mostly I take Judkins left and convert it to Judkins right. It is very important and very easy to do the same catheter for left and right, keeping the hard end of the wire up to the primary curve of the Judkins left and rotating it, and easily it sits into the right coronary artery. And once it enters into the right coronary artery, it sits very nicely. But it is told not to do several times, making the left to right, then it can cause dissection of the proximal part of the right coronary artery. I like to add only this few things from my small experience. Thank you all for participating. Participants, speaker, as well as the arranger, Dr. Professor Wadud and Dr. Mohsin. Thank you.
Thank you, sir. We come back again to our fellow faculties. Also, please, our another top topics, Dr. Timir Paul. He's waiting from the USA. I think a busy schedule. And after that, we come back again, our faculties. Lots of faculty, Dr. Samsmona, Dr. Sabir Rahman, Dr. Arun Maski. Sorry, I come back again. Dr. Timir Paul, he is the Associate Professor, Division of Cardiology, Director, Interventional Cardiology, Associate Program Director, Cardiology, Director, Cardiovascular Research, Whelan College of Medicine, East Tennessee State University. You know everybody, he's a student of Dhaka Medical College Hospital, the extraordinary physicians and teacher. Dr. Timir, please welcome our session. Dr. Timir.
Yeah. Thanks, IPDI, for inviting me today. It is an honor to give this talk First I want to share my slides and then we'll see.
Okay, nice.
Can you see the slides?
Yes, nice. You okay?
Can you see now?
Yes.
You okay now.
I can't see any of your faces, but I think I can talk with these slides. Everybody's seeing that. Can you hear me?
Yes, you hear me. Plus, you should screen should be enlarged.
Screen, I put it enlarged in full, but it's not. I have two screen. That's probably an issue. Let me. You're not seeing the full screen.
Full screen, but another you see the also you see the notes also there. Some
Oh
notes.
no, that's the two screen.
Yeah.
How about now?
You just off your another screen.
Okay.
Timmy, the next is also being seen. So if you just make only one slide.
I think you at first stop your screen, share your screen, then again you share your screen.
Okay. Let me.
Timid talk is the.
I have two screens, so
yeah.
like I think that's so. I'm.
You just share your screen, okay?
Timmy, do as you feel comfortable.
No, the issue is I don't want to show you the. I have two monitors, so that's, I don't know why it's coming in a two.
Okay. Start sharing now.
There is on presenter view. You have to exit the presenter view.
Yes. Use a presenter view.
That is also good. Someone comfortable with this one, because sometimes they got the note.
No, I don't need the notes. I don't have nothing, but just how about now?
Okay, nice. You full screen. Okay,
is
slide share.
Okay, yeah. Okay, let's do this way because
the slide is.
Okay, excellent. Again, good evening, everybody. I apologize that I cannot make all these sessions because you know that is peak of the day now. It's 10 o'clock. We started, but it is an honor to give this talk. Thanks again to IPDI and special thanks to Dr. Mohsin and Dr. Abdul Wadud Chowdhury for inviting me. Today we'll talk about the balloon design selection and implications. Sorry, can you hear me?
Screen should be bigger one. You just put the icon and big screen. Okay.
Yeah, but if you put the big screen, it's going to
press F5 or press F5.
Huh?
Press F5.
Press F5.
Yeah, I did, but it's not working.
So I think it's okay,
now
sir.
You can go with the slideshow.
It's okay. It's okay.
This is slideshow, but
that's good. That's good. I think that's good.
That's good. Okay.
That's good.
Okay.
All right. So today we're going to talk on balloon design, selection, and implications. Nothing much to talk about the balloon. It's not as important as diagnostic and guide catheters. As I said, that balloon is balloon. I think most of the balloons, is just 90% of the work you can do with the same balloons, like one balloon is enough most of the times. But I will try to discuss in next 20-30 minutes some of the important features of the balloon and how to select it and what is the important aspects of the balloon. I have no disclosures. So we'll talk about the balloon design very simply. I don't want to go in details. We want to learn from each other at the end. Most of the learning we'll get from discussion. We'll talk about the types of the balloon, characteristics of the balloon, some specialty balloon that some of them very new that came out, atherectomy balloon and drug-coated balloon. So the first balloon angioplasty started in 1977 by Dr. Andreas Guntis, and as you can see here, that Dr. Guntis is holding his balloon here. This is the first balloon angioplasty he did in 1977, and it was a pretty good results. As you can see, he did balloon angioplasty first, then 2 days later he looked at it, and then later on, you see that 1 month later it's still open, and 10 years later it's still pretty good. We don't see that balloon angioplasty results nowadays. If that was the case, then we did not need any stent, but restenosis, of course, is a major problem, and we have drug-eluting stents and bare metal stents now. This is the same slides, just in a bigger view, that you get very severe lesion, did some balloon angioplasty, and this is the final results of Dr. Guntis' balloon angioplasty. So there are broadly 2 types of balloon. Mainly one is called over-the-wire balloon, and the other one is called rapid exchange or monorail balloon, with RX or monorail. Also, there is one type of balloon called fixed wire balloon. You go with the wire and balloon together. We don't use that anymore. I never used that balloon anyway in last 8 years of my individual practice. There are another way you divide the balloon as kind of called compliant, semi-compliant, and non-compliant balloons. Depends on the compliance of the balloon. What are based on the functionality, we also divide the balloon as perfusion balloon, drug-coated balloon, and so forth. There are some specialty balloon we call cutting balloons or angiosculpt, and also there are some CTO balloons, basically nothing but a small diameter balloon. So when you select the balloon or when you discuss of the balloon, there are 5 characteristics of the balloon that particularly talk. One is the entry, like how we can push the balloon and how easily you can cross the lesion. That's one part. Second part is trackability, meaning that is it a O3, is it over the wire, of course, or rapid exchange, but is it a 018 compatibility, 014 compatibility, or 035 compatibility? So like, is it tracking the tortuosity well? Is it tracking the bending well? That's called trackability. And crossing depends on the crossing profiles, like and also balloon tip and the transition angle that will show in next slide. Like how is it a low profile crossing balloon or high profile, or basically it's a thicker balloon or thinner balloon, and transition zone depends on the crossability. Dilatation depends on the what kind of materials we used and also how much you have from the tip to shoulder. And withdrawal, we call withdrawal, meaning the rewrap. Like once you take the balloon, can you use the balloon again? Like how much balloon rewrap and came back to an original shape or close to original shape. With the balloon materials, the dilating part, it depends on the compliance and the burst pressure. As you can see here, the how much pressure you want to give, and depends also in compliance. So it comes together and is give you the effectivity of the dilatation. And like cutting balloon does not get, once you open it up, it does not get rewrap completely. So that is a problem with the cutting balloon. Tip transition, it shows how efficiently you can cross the balloon, and also it's called entry profile. Balloon transition is important to cross the balloon, but everything here is balloon materials to everything is basically crossing deficiency. Without further engineering technology, we just go to next slides and we'll discuss the compliant, non-compliant, and semi-compliant balloon. I don't think we need to know in real life how and what materials is made of, but in short, compliant balloon is usually made of polyurethane or silicone, and non-compliant balloon is made of mostly the nylon and polyester. So it can give you high pressure without most burst. And semi-compliant balloon is called mid-pressure balloon. So there are 3 types of balloon pressure you all know, or I am sure the new practitioners and the fellows already know by this time. There are nominal pressure. Nominal pressure is the pressure at which the balloon reaches at its stated size. Like if you have a nominal pressure is 12 and balloon size would be like 3.5 or 3, it will at 12 atmospheric pressure, it will be 3 or 3.5. Rated burst pressure, meaning that 99.9% of the time, if you don't exceed that rated burst pressure, it will not burst. But if you go beyond the rated burst pressure, there is a 0.1% chance that it can burst. Usually still it does not, but it's for the safety purposes. So you can even go beyond the rated burst pressure, but usually you should not. And working range pressure is between the two pressure, between the nominal pressure and rated burst pressure. We call the working range pressure. It's usually applicable for the semi-compliant balloon. Compliant balloon, it increases the diameter in ratios with increasing pressure. That means that, like if you put the 12 atmospheric pressure, it will give a diameter, more diameter compared to 6 atmospheric pressure. If you give 18 or 20 atmospheric pressure, it will relatively increase the diameter with increasing the pressure. A non-compliant balloon, no matter how much pressure you can give the very high pressure, but it will not expand too much. It will still maintain the size and shape regardless of the pressure you put. So very important concept, that non-compliant balloon. And semi-compliant balloon we don't use in general, sometimes we do. With this graph, I don't want to pay too much attention. It's a lot of balloons here, but I just want to emphasize in the red, at least the red one. You can see the red one. Red one is still in the kind of semi-compliant range. But if you look at the yellow yellow line here, and you can see if you put the, if you have a 3O balloon, and if it's a non-compliant balloon, and it's pretty much parallel to the 3O balloon. This is the one of the most non-compliant balloon in this graph. But if you look at this green line, and you can see how the compliant balloon increase the pressure. So compliant balloon is increasing the pressure. As you increase the pressure, diameter will increase. But non-compliant balloon remains pretty much the same. It increased, but it's not proportional to the pressure. And this has happened when you use the compliant balloon in a calcified lesion, or you don't have to be calcified, very fibrotic lesion, or we call resistant lesion. And if you increase the pressure, it will not expand this mid portion, that is your target that you want to expand, but it will expand either side. And if you expand in either side, that will cause you creative dissection. So it can cause a compliant balloon. If you put in the calcified lesion or resistant lesion, it can cause edge dissection. At the same time, if you put the non-compliant balloon in a calcified lesion or heavy tight lesions, or like very resistant lesions, you can see here that it expands not only the targeted part, but it does not expand at the edges. So this is a very good balloon for resistant lesion or calcified lesions to prevent the dissection. And don't confuse with the burst pressure with the compliance. Burst pressure is completely different. Burst pressure, as I told before, that is a pressure at which the balloon will not burst or will burst, either below or above. But non-compliant balloon is completely different. It depends on the consistency and depends on the material of the balloon. So it's totally two different concepts. This is a nice slide that you can see. In the middle is the semi-compliant balloon, on the left side is the compliant balloon, and right side is the non-compliant balloon. And you can see if you use the compliant balloon, is very highly crossable, easy to cross. If you want to use in the very tight lesions, tortuous anatomy, if you want to cross, this is compliant balloon is the best. At the same token, if you want to use in the heavily calcified lesions, if you want to do post dilatation, you should use the non-compliant balloon. Is in this side. So pre-dilatation, most of the time you use the compliant balloon. Sometimes you can use the semi-compliant balloon. It's highly crossable and it tracks very well the tortuous anatomy and very tight lesions. Non-compliant balloon, mostly, or I would say post-dilatation and calcified and resistant lesions. This is a typical balloon parts. I don't need to go in details of the engineering parts. It's not clinically that relevant, but a typical balloon definitely a balloon, and there is a balloon tip, and there is a port, oil port, that you have two ports. One is the guide oil lumen and one is the inflation lumen. And you have a shaft. Shaft also variable. You have a long shaft, you have a short shaft. So you have to think about what is the length you need. And also you have a manifold you hook with this. And in the balloon, there are some markers called bands or markers. These are the radio opaque marker. And you have a tapered tip. And this is the portion is the crossing profile. How smoothly is transition is there from the tip to the balloon. And this taper also, this is called proximal taper, or we call it shoulder too. And this is the shaft. This is basically the working length. The radio opaque marker will help you to precisely put that balloon in the specific lesion so you don't go beyond or after. So the balloon works from this to this, and this is the working length, and we don't worry about the shoulder because it will not expand, it will not cause dissection. But if this portion, the radio opaque marker, is beyond the lesion, then it can cause dissection. And in the same, this is a pictures, not the diagrammatic pictures, as you can the same thing, but radio opaque markers, shoulder of the balloon, and actually this is a diameter. This is the actual balloon diameter, not this. There are two types of marker. Most of the balloon have two markers, and we call dual markers. But there are some small balloons usually have a single marker that helps you to precisely put that marker in the mid of the lesion. A lot of time, if you have a very tight lesions, you don't usually see much. You put the balloon, you give the contrast, and you don't see the lesions. So while you are putting the balloon, you keep giving the contrast, and as soon as you're in the lesions, that mid marker will help you to precisely put the balloon in the lesions. So all the small balloon, or most of the small balloons, has one marker, mid marker. But other than that, most of the balloon has two markers. It will help you under fluoroscopy to place to proper placement. Here, this is a non-compliant balloon. I'm not affiliated with any company, or I don't have any associations with any company. I'm just putting to give you the example here. I think the all balloon is pretty much the same, no matter what company is used. This is a NC track balloon, and this is the 12 atmosphere, and this is the 20 atmosphere. These are the marker bands, and you can see from 12 to 20 atmosphere, because it's non-compliant balloon, this diameter did not increase. It is giving quite bit of nice expanded pressure, but it did not expand it too much beyond that lesion, even if you increase the pressure. And same thing in different way that we discussed. This line is very parallel to the 3O. If you have a 3O balloon, so it does not expand. And this, if you use the compliant balloon, it will expand exponentially. So you cannot feel, or you cannot tell by looking at the balloon whether it is compliant, semi-compliant, or non-compliant. But sometimes you can recognize if this mid marker is smaller size. Most of the mid marker smaller size balloon have very high crossing profiles, and we use this balloon as a CTO2, and you see there is a longer tip, smooth transition, and small shoulder, so it track and it cross the lesion pretty nicely. If you feel it, when you feel it with the balloon, after the balloon pressure, you can tell whether it's non-compliant and semi-compliant balloon. When it's folded, you cannot tell unless it is level. So these are the balloon sizes we have. The different company has the different balloon sizes. Most of the balloon is up to 4 millimeter size. This track balloon, they have both above the over the wire balloon, and also have monorail balloon. 2.25 millimeter to 5 millimeters balloon they have. Also, if you have a mini track, they have also both over the wire and rapid extension, and they have a 1.2, 1.5, and 2O balloon. Actually, the 2O balloon we don't consider as a mini balloon. This is my workhorse balloon. Like if I have a STEMI, I just give me a 2O12 balloon. They already make ready, and I just go blindly. And most of the time, you use the 2 or 2.5 balloon for PDL. 90% of the cases, I would say. And very rare cases, you need the 1.2, 1.5 balloon if it does not cross, because this smaller balloon is very ultra low profile and have outstanding crossing profile. This is just to show you that this track and mini track balloon, there not only they have a 1.2 to 2 mini track, and they have 2.25 to 5 millimeter balloon diameter. So they're basically, they have 1.2 to 5 millimeter balloon, and there are different sizes, 6, 8, 12, 15. This is the most commonly used balloons. And they have also 20, 25, and 30. But every company is different. As you can see here, the Medtronic balloon, they don't have any 5.0 or 4.5. They have 1.25 instead of 1.2. Here you have a 1.2 balloon, but here is a 1.25, and they go gradually up to 4. And they don't have 5.0 balloon. If you want to do the non-compliant, like left main, if you want to do pot, or if you want to do really aggressive post dilatation with 4.5, 5.0 balloon, then you have to go direct non-compliant balloon. Same thing here, and you see they don't have a much longer length. They have 6, 10, 12, and 15. That's they all have up to 4, and they have 15. But they have not only 15, they have 20, they have 25, they have 30. Although we don't really need that longer balloon until you use the 38 stand or 42. Now they have a 48 stands for synergy, and Boston Scientific you can use instead of a smaller balloon for post dilatation. You don't have to go multiple inflations, so you can use 20 or 25, but you have to be very careful unless it's long lesions. So this track balloon have newer one. They have some specific technology that they're using called slim seal technology. The balloon, they have 2.5 to 3.75, and they have in the past they have a cross flex technology, and basically they're showing here this is very crossable compared to the other balloons. And we also have a single marker 6 millimeter length balloon, the shorter balloon. Not only the diameter is shorter, 1.2 to 1.5, they have also 6 and 8 shorter balloon. So it also helps in sometimes to cross the lesion. Other than that, most of the other balloons have dual marker. When we use the over-the-wire balloon? Over-the-wire balloon I use, or most of the people use, to deliver the medications to prevent no reflow. Suppose you are doing a SBZ lesions or any other lesions, and you see suddenly no reflow, and you want to give some verapamil, adenosine, nitroglycerin, nicardipine, whatever you want to do, you put the over-the-wire balloon, take the wire out, and give precisely distal part, use that balloon to give the distal medications to increase the flow. Also, if you cross the CTO lesion or maybe subtotal occlusion 99% stenosis, you don't see distally much, you cross the wire and you put the over-the-wire balloon, and then you aspirate the blood to see if you're in the true lesion or not, like a true lumen or not. So that will help us when with the over-the-wire balloon. Also, I use the over-the-wire balloon as an extends wire, like a microcatheter. Most of the time I use the microcatheter. I used to use the extend, like over-the-wire balloon to extend the catheters, but microcatheter is expensive, over-the-wire balloon is inexpensive. I think it's Bangladesh perspective, over-the-wire balloon would be more cost effective than using the microcatheter. Like if you want to use the wiggle wire, stent is stocking with something, it's very easy to put the over-the-wire balloon, put any wire, Viper wire, Rota wire, wiggle wire, any support wire, like Grand Slam Ironman is very steep wire, is very hard to put in the distal part. In that case, it's very effective to use the over-the-wire balloon. So basically 3 situations to give the distal medications in the distal part, to confirm the true lumen and extend the wire. Balloon dilatation, some general concepts. POBA era, we are not in the POBA era anymore, but we just want to compare here, but we are focusing the stent era. So not everybody does pre and post dilatation, because if you do pre and post dilatation, you have to use the 2 balloons. But I do 98, 97% of my cases use always the pre-dial and post-dial. It gives me a lot of information. I can know the size of the, so I do the pre-dial and I give a nitro. I see what is the size of the lesion is, what is the size of the vessel, how is the balloon is behaving. So it gives me 4 ideas if you do pre-dilatation. One is what is the diameter of the vessel, and also what is the length of the vessel. It also gives me how the balloon behaves. Is it, if I put a stent, does it, do the stent will expand completely? So I think it's very important. And of course, the post-dilatation is very important, aggressive post-dilatation to prevent the in-stent stenosis to the proper size of the balloon. In the past, it was all just one balloon because we have stand now. So balloon size, you can still use 1:1 balloon ratio. Most of the people use that. PDL is not a big deal. If you have a 3.5 vessel, 3 or 5 vessel, you can use 2.5 just to do the pre-dilatation. But 0.75 to 1:1 is to ratio balloon is most of the people use. Balloon length, of course, have to be shorter than the stent length, or just to barely open that lesion segment. Okay. Compliant balloon used for pre-dial, non-compliant balloon is the post-dial, but you can use the non-compliant balloon pre-dilatation too, if you think that is too resistant balloon or too calcified lesions. But you can use whatever it takes to cross and dilate. Duration of the inflation in the past, of course, when we did not have any stent, we used to 5-7 minutes or at least 3 minutes. Now 35 to 45 seconds. Or if you put the balloon 20 seconds, 30 seconds, and you started seeing ST elevation or ST depression, then you just deflate the balloon right away. So those are the general conception. When we use the high pressure balloon or non-compliant balloon, of course, the calcified lesions, post-dilatation, or if you want to do the pot, shorter balloon, if you want to do the bifurcation lesion, then it's very important to use the non-compliant balloon for the pot with the shorter balloon. So post-dilatation and calcified lesion is the most important, because we do not want to regret, we call it stent regret, like rotor regret, stent regret, like we put a stent and then it's not expanding. Then you have to use a lot of other technology like the laser and something else. There is a new balloon called chocolate balloon. I use a few times. Mostly I use for the peripheral, but it's a very, very good balloon. It's a high pressure non-compliant balloon. It have less chance of rupture even if you go to the very high pressure. I'll show you because this is the chocolate balloon. As you can see here, is it's a predictable uniform atraumatic dilatation. The way it's been developed, there is some multiple pillows and gaps in between. So when you give the full pressure, it does not expand suddenly, and it does not do the plaque shift too much. The plaque hold in between the pillows. So it is a very, very effective effective balloon, for post dilatation or even the pre-dilatation in some cases. I don't know. I'm sure it's very expensive, so it's not all practical. So if you have a difficult lesion and if you want to cross, I have a couple of situations, and then what type of balloon you use. Of course, you use the smallest balloon and smallest like a diameter balloon. We have 1.2, we have 1.25. That's the commonly used balloon. 1.5, we also have mini track. So basically, ultra low profile design and most flexible balloon, shorter balloon we use to cross the difficult lesion, like very tight lesion, 99% or more than 95% lesion, called super crosser. Now we have a sapphire balloon. Is CSI company, they invented this sapphire balloon. It's a 1.0 balloon. I don't know you have in Bangladesh or not. I used in 2 cases and really helped. So sapphire balloon is sapphire also. This is like a track and mini track or other. Sapphire also have all sizes of balloon, but mostly we use this single marker 1.0 balloon if 1.2 or 1.5 or 1.25 does not cross. If you have the lowest crossing profile, you put nominal pressure 6 and it will expand. And then once you put the 1.0, then you can do rotablation. If you want to, you can do CSI catheter, or if you want to expand a little bit more, you can use the 1.2, 1.5 and gradual inflation as needed. But it will give you a micro channel. It have excellent pushability, excellent crossability. And it also come both over the wire and like a rapid extents. Nowadays, we don't use the over the wire balloon pretty much. I think the 97% cases we use the rapid extents, but all peripheral balloon is the over the wire balloon. This balloon also have a hydrophilic coating compared to any other company, even in the bigger one. So it has more slippery slope, so you can go easily. This is very important. I learned this even to give this lecture. I didn't know before, honestly. Although you can see here, I was surprised that you can see there is a Chowdhury balloon 1.5 compared to 1.2. We thought that okay, 1.2 balloon will go easily, compared to 1.5, but it's not the case. Of course, the 1O balloon, sapphire balloon, is the lowest profile, best entry profile, but even if you have a Takaru balloon 1.5 is as good as the sapphire 1.0. So if you don't have sapphire 1.0, then you can use the Takaru 1.5. It's better than the 1.2, 1.25, 1.2. As you can see, these are all the 1.2, 1.2. I didn't know, so I used to use the give me 1.2 millitrack and it's not going. Then I have to use the sapphire, but Takaru balloon is very, very good. And as we can see here, even the larger balloon compared to the 3O, see the 3O balloon, splinter balloon, all are 3O, but there is a difference between all 3O balloon. Minor difference, but it helps sometimes we need to. But I don't think the bigger 3O balloon, 3.5, 2.5 balloon is that much difference compared to on the left side of the screen. That the smaller the balloon is the most important. This larger balloon, you can use anything. Okay. So if you have a balloon undilatable lesions, what you can do? Of course, you start with the high pressure non-compliant balloon first. Chocolate balloon is very important, very good. It will not give you dissection. You give as much pressure as you want. If that does not work, or if nothing going, we put another body wire, and you can start using the regular non-compliant balloon. It will give you more room to go the further balloon. If that does not work, you can use the angiosculpt or cutting balloon. Angiosculpt also is a balloon. Then you can do any other atherectomy, or at the end you can do laser if you have options. But always make sure you pre-dilate enough, 1:1 size, and you know how the balloon is behaving so that you don't have under-expanded stent. Or if you use the BBS, now we know that you have to have a very aggressive pre-dilatation and post-dilatation to prevent the in-stent thrombosis. Cutting balloon atherectomy. Cutting balloon is from the Boston Scientific. You have a different size and different morphology. Usually the 3 or 4 sharp metal microtomes mounted on the non-compliant balloon. So it incises the coronary atheroma when you inflate the balloon. You can see here, this is a blade outside the balloon. And this is the newest generation of the cutting balloon. It's called Wolverine, Boston Scientific, and you can see has the same blade, but you have some mounted in two places instead of 3 or 4 places, and you have more crossability. So cutting balloon is a very bulky balloon. The issue is a good balloon for calcified lesions or osteal lesions, but if you have a very high profile, so it's difficult to cross, and sometimes it does not go. So the older generation of the cutting balloon was Ultra 2. I never used it that. Most of the time I use the Flexum cutting balloon. Is available over the wire and monorail. It has 6, 10, and 15 millimeter lengths, and all size of balloon in 2.0 to 3.25, and also 3.5 to 4 millimeter balloons. Most of the times cutting balloon, you need probably 2.5 or 2 or 3, 3 or 3.5. So cutting balloon in general everything is less compliant or non-compliant balloon. You have to be very careful. So it's a blade. So it also is fractured the calcium, but it can hook with the calcium. Or if you have a stent, most of the time cutting balloon you also use for in-stent restenosis. So you have to make sure that your wire did not go under the strut or through the stent strut. If that happened by any chance, and then if you use the cutting balloon, that when you inflate the blade, it will stuck in your stent strut and it will not come out. So we have some other tips and tricks for that. All cutting balloon atherectomy use the slow inflation and slow depletion. That will not perforate, that will not make the vessel dissected. So, and you don't use the very high burst pressure or very high pressure for the cutting balloon. You need the nominal pressure. So slow inflation, slow depletion, nominal pressure using cutting balloon is the most effective way to go. When you use the cutting balloon, very important, if you use in-stent restenosis, cutting balloon is very, very effective. You don't have to put another stent, especially if you have 2 layers of stent already. I use the cutting balloon first and see how it goes. After the cutting balloon, I use non-compliant balloon or chocolate balloon and see. Usually, most of the time, it's got a good results, but I don't know long term it will be how much effective, but at least temporarily it will give good results. The cutting balloon does not slip. So if you use the non-compliant balloon, it tries to slip like a melon seeding effect. But if you use the cutting balloon, it will not slip. So it will. So for in-stent stenosis, and especially it's very helpful for any osteal lesions, osteal fibrotic. Most of the osteal lesion is fibrotic lesions. If you have a bifurcation lesion, if you use the cutting balloon in the side branch and just put a stent in the main branch, you can do that, and it will give you a very good results and avoid one other stent. So it usually also does not do too much plaque shift. So any resistant lesions, you can use the cutting balloon before you use the rotational atherectomy. Rotational atherectomy is better if you have it and if you use it effectively. Advantage of the cutting balloon is the control. You make a dissection. That's the whole purpose. You're doing a dissection. It's a micro dissection, but it's a controlled dissection, and it's very helpful for osteal lesion and in-stent stenosis. A disadvantage is costly. It's a high crossing profile. It doesn't. You cannot cross most of the lesions. You have some limited lengths. You have only 3 lengths. Very bulky, stiffer. And you have some chance of perforation, although not too high, very less than 1% chance of perforation and some dissection too. This is a newer types of cutting balloon, but it's a completely different technology called angiosculpt. This is from Philips. It is they put within instead of compliant balloon, they put this 19-hole wire on semi-compliant balloon. So basically, it's a flexible external 19-hole helical scoring ribbon, as you can see here, 3 helical ribbon, and it will give you the cutting scoring. Okay, and this is more compatible and more deliverable compared to the Boston Scientific cutting balloon because they have only the blades, and we have the flexible ribbon. So it's more. If you cannot use the cutting balloon, the situation if it's a little bit tighter, then you can use the angiosculpt. And this is a very low crossing profile. You have 2.7 fans, and this is alternative of the cutting balloon. Anytime you want to use the cutting balloon, in the same situation, you can use the angiosculpt or scoring balloon. This is the way the angiosculpt is ruptured the calcium. It's very, forceful pressure, and it just cracked the calcium. And it gives you stent expansion easily if you cannot use or if you don't have availability of the other atherectomy devices. Very briefly, drug-coated balloons is not really still effective. We don't have much data, but drug-coated balloon is useful is only in-stent stenosis. Like if you have one layer of balloon, one layer of stents, you still can use another layer or use the cutting balloon or use laser, but if you have options, in my lab we don't have any drug-coated balloons. So what I do in in-stent stenosis, if it's 2 layers of stent, I just use the laser. But there are some data that we don't have long-term data, but it would be helpful in in-stent stenosis cases. The guidelines is not there, but 2014 European guidelines said that it is a class 1 recommendation with the level of evidence for treatment of the in-stent stenosis, either with the BMS or DS. But if you have first time you have BMS, I would not use the drug-coated balloon. I use the DS first, and you see how long this stenosis lasts. I think this is. We also have some perfusion balloon. Mostly we use in the past. We used to use the coronary. We use a lot in the peripheral. If the patients come with the acute limb ischemia or acute thrombosis. But in the coronary, you have limited options. With that said, I think this is the end slide. I again would like to thank you to the organizer and organizing committee of the IPDI. And we can open the discussion forum so we can learn from each other, from the expert panel and from the audience. Thank you.
Thank you, Dr. Timir. I think the excellent presentation. I have learned a lot from your presentation. So I'm working because balloon, like guide catheter, balloon also most important part for the ending of the coronary intervention. So I'm asking faculties, Professor Abdul sir, please, Professor Abdul sir, do you hear me?
Yeah. I was actually listening to Timir very rapidly. It was very good. Timir, I think young generation will find it very useful for them.
Oh, thank you so much. But we can, I think there is nothing much to talk about the balloon I am not expert and it was given. So Dr. Mohsin told me, can you talk about the balloon? I said, no. I just said, okay, that's fine. But I'm not expert and I just try to make it simple for the.
It is nice. Make it simple is very much important. Yeah.
You are repeatedly pointing out, if you consider there is some calcium, please prepare the bed well and use 1:1 ratio or 1:0.75 ratio of balloon. If you do not predilate it, you will, if you put the stent in there, there is a high chance of under expansion of the stent. And Timir, have you used the opium balloon? The high balloon?
No, in our lab, no, I didn't use that balloon.
Thank you. Professor Dr. Mohammed Saidul Rahman.
Yeah.
Dr. Saidul Rahman, yes. Yeah.
Considering balloon, what I can tell that Timir, my fellow DMCN, so he has really touched everything in a very good fashion. So that's a very good batting from the side of Timir. And for me, just I can tell that for balloon, for any balloon, the delivery system, you have to, every fellow while doing PCI, you have to feel the delivery system, whatever the balloon you have in your docket. Like we have Sapphire, we have available balloons here, Trex and U4 also. These three type of balloons are we can deal with. So here the delivery system is very important, which I feel, because every operator has their own workhorse balloons, but I can tell that you have to feel the shaft also, because this shaft is also very important, because if the lesion is very hard, you have to push the balloon very hard, and while pushing the balloon, the shaft which is beyond the catheter, and you are pushing from there, and the shaft sometimes may kink and may be broken. So that is the dangerous part, that you will have to put the balloon out and you have to take another new balloon. This is one thing. And another thing is that while pre-dilating with a balloon, either it is a NC balloon, or it's a semi-compliant or a non-compliant balloon, or a compliant balloon, whatever it is. So whenever you are ballooning the tightest most lesion, and then later on you have felt that you need more ballooning, and you have pulled the balloon, and you may not cross the balloon again. So it means that while ballooning any lesion, so go deeper, far away from, so that you can balloon whatever the lesions beyond the tightest part also. So balloon first that one, and then can come to the tightest part. Otherwise, then you will have to take a new balloon, because already used balloon cannot be crossed sometimes. And the other thing is that I can tell, for especially for the CTO or for the tightest most lesion, why you will have to take smallest balloon. So we have Sapphire 1.255 available in our country, and also in few cases I have got some one size of Sapphire balloon, which has a very good lubricity also. That's a very beautiful most thing for Sapphire, rather than a Trek with 1.26. So rather than, it's better to take the 1.255 Sapphire in exchange of 1.2 into 6 millimeter Trek balloon. And for preparation of the balloon, always you'll have to take care of these things with your scrub, because wherever you are ballooning the fluid which they prepare, so that one, if it is too dense, that is they're giving too much contrast with water mixing, then while inflating the balloon, it will take a long time, and ST is elevating, and you are thinking that you will have to pull the balloon first, then you're seeing that the balloon is not deflating, is deflating slowly, because the fluid is very dense. So that is one of the thing most importantly. And the last point is that for post dilatation, whatever the length of the stent, nowadays I usually take smaller NC balloon rather than like in a 38 millimeter stent. So you can easily take a 15 millimeter NC balloon, which we are available, but it's better to take a smaller NC balloon to give much more and integrated pressure to the expected size where the lesion is malapposed. So I can tell that part only. Thank you.
Thank you. Dr. Kaisar Nasrullah Khan. Dr. Kaisar Nasrullah Khan.
Yeah, Assalamu alaikum and good evening to all. Thanks IPDI, and wonderful lecture by Dr. Timir. I learned a lot from you. Thank you so much. About balloon, I must say that to all the fellows that when you are in a war, you should know your armaments very well, and balloon is an essential armaments to win the war in PTCA. So you should know different varieties of balloon, how to use it. So as Timir has explained very well, that you have to know the compliant, semi-compliant, non-compliant balloons, when to use, and also the other balloons, especially for calcified lesions like angioscalps or oven balloons or cutting balloon, or nowadays the opium balloon is coming in our country, and then IVL, the intravenous lithotripsy balloons. We all have to know these things. And another variety you have to know very well, especially for CTOs, the short profiles and very excellent crossing profiles balloons. Especially, I would refer to Japanese balloon of Teremo and some other also Japanese company, which is a very good crossing profile. When you cross the wire after struggling for 1 hour or 2 hours, and you can't cross the balloon, so then you need this type of very good crossing profile balloons and to get in. And at the same time, you have to know how to inflate the balloon. How much will you go, nominal or burst pressure, when to go for the burst pressure, when to go nominal, and that is also another thing. And another variety of balloon you should be very much aware of, that is drug eluting balloon, especially for small vessels, long lesions, side branches, and ISR. You need these balloons, and you need to know that you have to inflate a longer to deliver the drugs in the lesions as well. Again, thank you so much. Learned a lot from you, Timir. Thank you so much.
Thank you all. Thank you.
Dr. Arun Maski, do you hear me?
Yeah, I can hear you. So thank you, Dr. Timir. I mean, this was a simplified but nicely presented one. One of the indications where you can use monorail balloon, you said you can use over the wire. So if you use a monorail balloon, cut it with a blade, and you can pass that balloon to the site of some obstructions. You can inject injection GTN or whatever things you can do. That's what we do rather than going with the over the wire balloon. So that one you can do. And your presentation was very nice and well presented. And what we do is pre-dilate mostly with the semi-compliant and post-dilate with non-compliant. That's what we practice, except in those lesions where there's a very calcified, then you do non-compliant. And one question to you is, like you are pre-dilating a lesions. So what is your threshold for putting stents? What sort of residual stenosis you would still accept to put the stents, whether it's around 50, 60, or what would be your recommendation to put stents? Because most of the time you find that you dilate with the 0.75 to one size artery, then still there's some residual stenosis. What would be your threshold for putting stents after pre-dilatation with the balloon?
We do a stent for all lesions. So even if it's 30%, 40%, 50%, even after the balloon dilatation, if you get like 10%, if you get completely like 10% residual or 20%, still we put a stent. So unless you do not plan to put a stent, so a stent is universal. So no matter what you do, unless the patient going for surgery, you don't want to put drug-coated stents recently within a month or so. Like in some situation, if you really want to put only balloon angioplasty, POBA, like plain balloon old angioplasty, like a old era, then you still have to have less than 30% to consider is successful balloon angioplasty. The definition.
My question was like you pre-dilate, and then still the vessel is not well dilated, even if it's 1:1.
Got it.
And so if the residual stenosis is let's say about 60%, so what would be your threshold of putting stents in those patients? Would you again go for aggressive pre-dilatation, or you would put stent and then go aggressive post-dilatation? What would be your strategy?
Very good question. I think even if it's 60%, 50% residual stenosis, if you think that no calcification there and balloon does not have dog bone, like if you know wasting in the middle, even if it's like, suppose it, I'm giving an example of, suppose it 3.5 vessel, and you use the 2.5 balloon, and there is a 60% residual stenosis, but balloon expanded pretty well, then you go directly with the stent, even if it's 70%, 60%, that's one. But if you see a lot of calcium under fluoro, even if you don't do IVAS, but if you see both sides calcium or one side calcium, if you think that there is a wasting of the balloon or if there is a calcification, then probably I would go use the non-compliant in 3O in that situation. So, but after the pre-dilatation, if you have 60, 70%, 50% residual stenosis with no wasting and no calcium, I would just go directly stenting, and stent will expand pretty well, and then we can do aggressive post-dilatation. I don't do like 2 balloons, even if it's 50, 60% lesions, unless it's calcified.
Dr. Maski, any comments or any questions?
No, thank you.
Thank you. Dr. Khanduk Asadujaman. Dr. Khanduk Asadujaman. Yeah.
Okay, thank you very much for giving me the opportunity to share some comments. Actually, the lecture was a very brilliant lecture. I have learned a lot, like our other fellows. But I want to add a few things. Number one, we have seen that there are most common use of balloon is pre-dilatation and post-dilatation. But for the radialist, we commonly use another use is to cross the spasm, that is the lesion when it is a severe spasm. We can use the balloon as a tools to overcome this spasm, particularly when you use the 5 French, we use the balloon 1.5, and when you use the 6 French, we use the 2 millimeter balloon to overcome this spasm. And also, sometimes it gives some extra backup support when we cross the tortuous lesion. It also helps us. And another important issue is when we face the calcified or fibrotic lesions, particularly in the CTO lesions. In that cases, we try to overcome these lesions by crossing the balloon. But sometimes, if you feel any resistance at the middle or at the beginning of the lesions, we can predilate the lesions and easily we can overcome these situations. So thank you very much. Thank you again.
Thank you. A few questions from our young brothers. Dr. Timir Ahmed. Yeah, Dr. Timir, do you hear me?
Yes, sir. Yes, sir. Thank you, sir. It was an excellent presentation. Thank you. And very interesting one as well. Sir, I had 2 queries. One, while dealing with CTO lesions, sometimes we use the anchor balloon technique. We have a small side branch where we would like to anchor. So what would be your choice of balloon while we would be anchoring? Would it be a compliant balloon or a semi-compliant or a non-compliant? Secondly, sir, in dealing with venous grafts in post-CVD patient, what would be the choice of the balloon to vessel size?
Thank you, Tanvi. Dr. Timir?
Yeah, let's answer the second question first. So for the SBC lesion, we want to do most of the time I'm expert on the SBC lesions of multiple commentary and the papers. So, and I'm still writing. Recently, if you go to the Sky website, that I just put a big tips and tricks for the SBC lesions. So my recommendation, I don't do pre-dilatation with the balloon. In general, like 99% of the, I recommend not to use the pre-dilatation balloon in the SBC lesions unless it's really tight, 95, 99%, or if you cannot put a stent or if the flow is completely, you cannot see. So because that will help you not to put any embolic protection device, you just put direct stenting. So when you put the direct stenting, you put a longer stent, slow inflation of the stent, and no even post-dilatation. So if you have a lesion length is 20 centimeter, you use the 20 millimeter, you use the 23 millimeter or 28 millimeter stent. If your vessel size is like eating 4.0, use the 3.75 balloon, 7.5 stent. So I don't use the pre-dilatation 95% of the time with the SBC lesion, and I don't recommend it. So that's the second question.
But
First part.
Timir, just I have a comment here. The thing is that not all the time, that's true, because direct stanting is better. Direct stanting is better for venous grafts, and overstretching is not recommended for venous graft. That's true. But at the same time, but lots of, especially to those who are that 10 years or 15 years after CABG. So in that case, the venous grafts will be very, very much calcified also at the same time. And if you don't do the balloon dilatation, actually you can't deploy a stand there. And at that time you need a balloon dilatation. The only thing is that here, even for SVG or even for non-SVG, the most important question is here that the slippage of the balloon. Whenever you are pre-dilating the lesion, the balloon is slipping beyond the stenosis most of the time. If it is very tight, if it is very calcified, and it's like a plate-like. So the balloon. So in that case, my own formula is like this: that pre-dilate again and again in a slow inflation pressure to make the surface of the balloon, outer surface of the balloon, a bit rough. So when it is rough, then it will be in the expected position, and you can pre-dilate it.
I agree with you most of the, sorry, let me, I agree with you most of the point, but one thing that even if it's older graft, 10, 15 years old, is very less likely to have calcified. Usually the venous graft does not have calcification.
But once in a blue moon, you can get it.
Yeah, once in a blue moon, but
you can get it.
Yeah, very rarely. Because the venous graft does not, it's a completely different pathophysiology underlying it. But if you have to use the balloon, sometimes you have to use the balloon, tight lesions, then I would recommend the way it's long, use the longer balloon and slow inflation. And
but the fellows in the general rule, venous graft, don't pre-dilate. In a exceptionally, Professor Saibur Rahman said, in a few exceptional case, calcified, but general rule not to do the pre-dilation, direct extending and slow inflation, slow depletion for the fellows.
Sir, I have a question to ask.
Yeah.
Dr. Arif, sir.
Yeah.
May I ask, sir?
Arif? Wadud sir, please comment.
Sure, sir.
One of the thing about venous graft is that they contain larger amount of debris. So if you make it, as you were saying, it's a 4 millimeter vessel, you use a 3.75, a little bit less, so that there is less prolapse of the debris material through the stent struts. And that creates less problem of no flow and no flow.
And exactly, sir. That is very important, the pathophysiology, because in native vessel, atheroma is the neointimal proliferation is the mechanism of restenosis, ISR. But in case of venous graft, if we undersize the stent, even without post-dilatation, chance of restenosis is relatively low.
Thank you, sir.
I think Wadud bhai, it's not only the restenosis, it's also the vein itself, because it doesn't have that much thick media. So you can't overstretch it. If you overstretch it, already the vasomotion capacity is very poor for venous grafts. It doesn't have that much vasomotion capacity. So it's better not to stretch it at all.
Right, exactly. Yes,
there was another question regarding the that is on compliant or non-compliant for anchoring balloon.
Yes, another question. Yeah, Dr. Timir.
Yeah, I'm not a C2 expert. I know that but for an anchor balloon, you can use compliant balloon. It's not a problem. Anchor balloon is have to be low pressure balloon. Anchor balloon, you don't have to be for only CTO. Sometimes guide is not engaging, guide is coming out, or any difficult lesions that you cannot cross the stem. So anchoring balloon, you can put a balloon in another small branch, and you just put a non-compliant balloon and just a low pressure balloon. You don't have to make sure that
Exactly.
Thank you, sir. First, I'd like to thank our two great speakers, Dr. Waliul sir and Dr. Timir sir. It was an excellent discussion. One thing regarding post dilation in vessels with important side branch, such as a big diagonal or big OM. In this lesion, if there is a minimal plaque or minor pathology is there in the side branch, in that case, we usually afraid whether an adequate post dilation, whether they are occluded or not. I want to know your experience or your suggestion regarding this type of ablation, where there is an important side branch with minimal plaque during post dilation. So that when we need any protection, or we can do it easily, there is so that side branch is not lost.
I just did a case yesterday, and the similar I had a similar concern, but this is a very big dual LED system. Like diagonal is bigger than or larger than the actual LED, very big vessel, and there was some ostial, I would say 40% lesion there in the LED, maximum 50, and it's only involved in the ostium. So I was prepared for everything, so I used the 7 friends guide to make sure. Then I was planning to for any like provisional stenting and all of this, but I took the approach of provisional stenting. So I just did a first balloon, put the 2 wires, and I put a balloon across the diagonal branch to the main LED, and then it looks okay, and there is no plaque sheet. So I put a big size stand. I used the 4-roll longer stand, so I have a more room to pot, just in case you have to cross. And so I did that. It was around 70%, 70-degree angle or less than 70-degree angle. It's a big LED, but I'm putting a stand in the diagonal 4-row. So I did that. I put my wire, and I see it was pretty good. No like pinching or no worse than the 40% or 50%. So excellent immediate flow. So I did the pot first and see how it looks. Did the pot, looks pretty good. There was a very minimal I would say wasting, very minimal. You can, so I did the aggressively post dilate. I took the 4.25 and did the whole things, another post dilatation. And everything went well, and I did not have to put anything in the diagonal, not even a balloon in the actual LED. So it depends. If it got pins, if it's more than 70%, or if you have still elevation patient has chest pain, then you do it. But you can do aggressive post dilation if you have osteal involved. But if it's a long lesion, and if your first balloon, 2.5 balloon or 3 balloon pedal, if you think that there's some plaque shift, then of course you don't do very aggressive post dilation.
I think Mohsin, this is a very Mohsin, this is a very important question. This is a very, very important question nowadays. And this is really, really a troublesome thing for every interventionist. Almost once a week, you can feel that one. So the benchmark is now after EBC, European Bifurcation Club, all the documentation, because before that, we were not that much aware of pot. So the pot is the most important thing now. And so for this reason, whenever you will have a side branch of a medium size, like more than 2.5, whatever big it is, but if it is more than 2.5 or more than 10% myocardium is involved, so in that case, take a stand. Even the stenosis is just beyond the in the bifurcation or just beyond the bifurcation. Take a stand, at least 10 millimeter or 8 millimeter. How much you have the size of the balloon in your docket? Like 10 millimeter NC, you have not 8 millimeter NC. So take at least 10 millimeter beyond the side branch proximally. The stand should be there, because to make a pot, so you have to make a pot. And before that, which you shouldn't hesitate to post dilate the whole stanter segment. Do post dilatation of the holes, because that is your primary thing. If you just by fearing that the side branch is getting plaque shifted and slow flow or no reflow will be there, so I'm not going to post dilate that much. That's not the thing, because my main branch should be very much perfect. So whatever the post dilation, you will do it. But later on, and you know that the distal below the side branch, the distal MB or the distal portion of the thing, that one will be the 1:1 ratio. Post dilatation balloon. And for pot, because the proximal branch is a little bit bigger, so take that in different balloon for pot, not the same balloon, what NC balloon, what you have taken for the post dilation of the stanter segment.
Excellent.
So, Dr. Arif, I think you're
Thank
asking about whether we'll vigorously post dilate or not. Actually, very frequently we faces the same problem. 10 years back, I can just share our concept and our experience. 10 years back, we used to do the less post dilatation so that diagonal maybe pins more, flow will be restricted. But now the concept Dr. Mishwar was telling, concept is totally changed. we vigorously post-dilate at the level of the diagonal and proximal to the diagonal. Even if the strut is opened up, that gives a better result, better flow, and subsequently native vessel restenosis is less. And if the flow is maintained through the diagonal, the chance of disease progression to the diagonal ostium, if it is disease, that is also less. So don't hesitate to post-dilate at the level and proximal to the diagonal.
Yeah, that's the you know, the Antonio Colombo's 10 years back theory, post-dilatation. That's the beautiful most theory he has invented. That is that post-dilatation means whatever at that time there was no pot, but the thing is that post-dilatation event can make the strut much more open, so the side branch will have much room to get some blood from the main branch. So after that, the pot has came, it make things much better.
Exactly.
Dr. Mohsin and all, sorry, I have to leave right now because I have to give another lectures to my fellows.
Yeah, Dr. Timir, thank you so much, Dr.
Thank you, sir.
Thank you.
Sir, sir, if you permit, sir, I have a question, sir. Sir, only one question, sir.
Yeah, last question from the Timir.
Sir, thank you very much, sir. Sir, if balloon is stuck within the lesion, how we should remove, sir?
Oh, this is a little bit longer discussion. I think all other experts can.
Okay, Timir, short, quick question. Who is going to be your next president?
I think Biden.
Biden. Okay, thank you.
Yeah,
Mohsin. Thank you, Timir.
Have a nice day.
Mohsin.
Professor,
thank you.
Thank you.
One question.
Dr. Mohsin, do you hear me?
Mohsin.
Just one question. Dr. one question for the challenging. You asked, you answered the question. When balloon is stuck, how remove the balloon? Was Amal Chowdhury. Yeah.
Mohsin.
Yes. Do you hear me?
Can I give compliment to the Timir? Dr. Timir, thank you for Timing and Wali. For nice. I was there from beginning to last. I was little sick. So I cannot participate actively.
You're looking sick.
Looking sick. So, thank you, Timir, and thank you, Mohsin and Wadud, for nice presentation, a nice arrangement, and I enjoy the lecture from since beginning, from 2 hours. Thank you, Mohsin. Today I like to ask, don't like to ask any question and critical question. So that thank you, Mohsin.
Dr. Aziz Roman, do you hear me?
But although you have to answer how balloon can be removed.
Dr. Aziz Roman, do you hear me? Dr. Aziz Roman? Dr. Aziz Roman.
শুনতে পাচ্ছি স্যার 2 hours. So
I have a question, sir.
When you
আপনি কি অ্যানসার করব এটা?
Yes.
কে বলবেন? অশোক দত্ত? Dr. Ashok Dutta, please.
Okay. For predilation, if the lesion is calcified, then sometimes balloon may be stuck. Usually, depletion is possible. But if it's not possible anyway, two things you can do. If it is proximal to the vessel, like proximal LAD, proximal LCX, you can engage the catheter deep up to the level of the balloon. Then you can pull it back. Or you can, if it is distal, then if the balloon is partially depleted, usually you should disengage the catheter and you will try to get it out. But the more difficult thing, if during post-dilatation, if balloon cannot be depleted, that happens to me today also, especially reused balloon, or when the some fabrics is inside or too much concentrated dye, sometimes may happen. This is very difficult. Then you have to dilute with normal saline. You have to remove all the dye. You have to take the normal saline with the inflation device, then gradually pull, like means gradually inflation, depletion, this way that dye will be diluted and gradually balloon will be depleted.
If not,
then Mominujjaman sir, I will take the help from
Mominujjaman sir.
Yes.
I,
Thank
I
you.
have experience.
I think I have got a peculiar experience.
One experience. Yes, sir.
I have got a peculiar experience of
Yes, sir.
what you are actually talking about. And only once it happened. Let me, very interesting. Let me tell you the whole history. I inflated the stent balloon. It was a stent balloon. After the deployment of the stent, the balloon didn't recoil, and it remained there. I tried to burst the balloon. It didn't happen because I'm talking about say 15 years back. That patient had an inferior MI, so infracted right coronary. There was not much of hemodynamic problem so far. Then, whatever the technique at that time, because I have not seen it. Now nobody around me to help me. The same thing I did, dilute the, remove the device and attach with a 50-16, pull it, maintain a negative suction, then pull it. But once I pull it, the guiding catheter go inside. So after struggling almost half an hour, I stop it and ask my surgeon to do bypass surgery tomorrow and remove the balloon. And whole night I couldn't sleep. The patient was kept in the ICU, and Jahangir was ready to do surgery the first case. He started first case at 7 o'clock. Whole night I couldn't sleep. Early morning at 6 o'clock I went to hospital, and I had a plus been given me as a gift by GE Engineer, fresh plus, new brand plus. I cut the hard end of the
balloon catheter,
coronary wire, just obliquely. It was so sharp that while just checking it, it pricked my finger. Then I put it through the guiding catheter and slightly deep throat the guiding catheter, because it was just middle of the RCA, very close to the balloon. Then I pushed the wire, and that wire punctured that balloon. After that, it was easy for me to come out. That was my really experience. This was, nobody informed me to cut it like this. It was just, the intervention is the innovation, simply.
Yes.
And sometimes you may not have anybody around. Nowadays, a lot of people are around you. Your senior is there. So that was a lesson to me. Nowadays, all reuse balloon. I always inflate the balloon to the highest rated burst pressure to see the balloon is inflating well or not. Because the balloon, initially, I personally used to prepare the balloon for the next day. In an ICBD, I personally use that balloon, reusability, to reuse it. I personally wash the balloon. What I used to do, I inflate, deflate, and finally I keep the full normal saline inside, connect with the three-way, and lock it, keep it in the side X. And the following morning, I wash it out and then send it for ETO. Nowadays, PCS used to wash it out. So it matters unimportant to him to remove the dye. Moreover, sometimes the dye itself becomes solidified, it crystallized, and that can block the hypotube. So if you don't test it before entering into the, sometimes it may create a problem. What is the stacking?
Exactly,
Somehow it will inflate, but may not deflate. That is my experience that I share with you.
Thank you, sir.
Thank you, sir.
Sir. Yeah.
Something. One thing is that we used to We used to wash the balloon with normal saline, but remember that sometimes if you put the normal saline, then it crystallizes. If you wash it with simple water or distilled water, there's less chance of having. You should remember that.
Yeah, Wadud bhai.
Yeah.
Wadud bhai, just can Dr. Mohamed is going to recommend this technique to the fellows to do that one?
No.
Nowadays it is more simpler.
Yeah.
Yeah, nowadays because you have got microcatheter. You can go enter up to the tip of the and see 1.0014 wire. Yeah, it will not create much of problem even if it perforate the artery.
Until and unless the catheter is going near the standard segment, because if it is then beyond the near far away
then
from
you can
the
use the
distal
microcatheter.
segment,
You can
then
use the
you have to use the
microcatheter.
microcatheter.
You can use
Yeah,
the
but
microcatheter.
last year I in the Euro PCR there was this session like this that for
yeah,
this
I was there. I was there.
for this
I
was unfortunately the faculty there, and somebody from Iran and some other places they were presenting some cases, and they were telling cutting the catheter, making a mother and child catheter, and the smaller catheter like the 4 French guide catheter or the 5 French guide catheter in the 6 French index catheter which we have there. So that 4 French guide catheter, the tip of the catheter he has to cut and sharply in obliquely, and then they are pushing it through and also the balloon delivery system has been cut a little bit, and through all the delivery system they are pushing that catheter down to the balloon and pushing it so that it can cut the balloon surface. That is one thing. And another one thing is that put another wire and somehow try to go by the side in between the stent and the balloon, and a smaller caliber, small size balloon to put. And because I don't think that this is practically possible or not, and how much is possible. In my life, one time because it was a faulty stent technique, the faulty stent was there, so the balloon was not deflating, and at that time it was like that. Fortunately, inflating again and again. Then some way I've been able to pull the stent, but always the coiling of the stent is a possibility there also.
Thank you.
One more interesting story. Have you got any experience of stacking the mitral balloon inside the LA? That is also balloon.
Yes.
Have you got any experience of stacking the mitral balloon inside?
No, sir.
No, sir, not yet, sir.
So have you taken as have you taken a 0.35 wire there?
No. No, mind it. I am fortunate in a way. On those days, nobody was around me. Simply whatever I have done with my own knowledge, and I don't know. God help me.
A bigger wire or
subsequently, I have seen many of the document in paper. What I have done there.
Same wire, same thin wire you have taken there?
No. It is the broken balloon needle.
Okay.
Broken balloon needle pass through the opposite port.
Okay.
With the fluoroscopic guide, because if you see the anatomy of the balloon, there is a hypotube inside.
Yeah.
There is one more balloon around. There is a nylon mesh, another balloon. What happened? Somehow the inner balloon, it punched. Somehow inner balloon entered to the outer balloon through the mesh and strangulated.
Okay.
So what I did, the broken balloon needle with the fluoroscopic guide, I entered to the punctured the hypotube, because you are seeing it. Yeah. And be careful about it, should be in the middle, not in any other place.
Yeah, that's it.
And then I punctured that one. Finally, I search it. It is the technique. I have not gone through, but after that I found, yes, this is a technique to remove the Inouye balloon.
Necessity is the
maybe
mother of
some
invention. Okay. Thank you, sir. We are passing short of time, 2.5 hours. Thank you, sir. Dr. Anisul Awal, question for you, Dr. Anisul Awal.
সোহেল ভাই আমার নিজেরই এরকম হয়েছিল, আমি সব টেকনিক ফেল করার পরে আমি দেখলাম পেশেন্ট সিঙ্কিং, আমি টিপিএম করলাম, সিপিআর দিচ্ছি, কোনো প্রসেসে বের করতে পারছি না, তখন আমি জেন্টাল পুল করলাম, পুল করে আমি অলমোস্ট স্ট্যান্ড শুদ্ধ মনে হয় সব বের করে নিয়ে আসছি এই অবস্থা আর কি, কিন্তু যখন পুল করে চলে আসলো আবার দেখি আবার রিপোজিশন হয়ে গেছে। So that's the thing happened to me. So আমি পরে দেখলাম যে লিটারেচার আছে যে হ্যাঁ যখন you can make a gentle push and pull করে এটা বের করা যেতে পারে। আর মহিনুজ্জামান স্যার যেটা বলেছেন ওরা দেখেছে যে বেঞ্চে বেস্ট ওয়ে হচ্ছে বেলুন ডেলিভারি সিস্টেমের প্রক্সিমাল লাইনটা কেটে ওইটা দিয়ে মাইক্রো ক্যাথেটার দিয়ে এটা পাংচার করা, ওইটাই বেঞ্চে যে প্রুভেন যে এটাই সবচেয়ে ভালো কাজ করে।
এক্স্যাক্টলি রাইট। ডক্টর আজিজুর রহমান, Dr. Azur Roman.
Sir, thank you, sir. I have a simple question. Sir, I have a simple question. In case of push dilatation, should we use same size balloon? We use the stand, same size balloon, or higher size balloon in case of push dilatation?
Professor Mohsin, sir. Yeah.
That's simple. There should be a ratio of 1:1 to the actual vessel size. If you put a stent in a vessel of 3.5, placing a stent to match the distal end with the 3 mm balloon, you will have to dilate the proximal segment with the 3.5 balloon. Maybe distally with the 3 balloon because it should not cross the size of the actual size of the balloon. But proximally, even you can go up to 4 mm because nowadays the stent can go a little bigger diameter than the previous stent. So distally you can match with the actual size. Proximally you can post dilate with and it should be non-compliant balloon with a higher size balloon. This is common practice.
Thank you, sir. Dr. Khaled Mohsin, sir, do you have any comment? Dr. Khaled Mohsin, sir?
Actually, a lot of discussion made. One thing we need to emphasize that we have to take account of the configuration of the stent balloon as well. The overhang of the stent balloon is very important. Actually, we need to know what stent has what magnitude of overhang. Otherwise, if the overhang we cannot consider it, there may be some edge dissection when we are inflating the patient. So these are semi-compliant balloons, and we need to take them into consideration as well. And we have to very much aware of the magnitude of overhang. That is one thing. And another thing, though Dr. Timir has left, I think there are two other special use of balloon actually in some emergency situation. One is the clear stream balloon for infusing some light agent or anything inside the
Khaled bhai, the company name is Clearway.
Yeah, Clearway. And another is the perfusion balloon. Actually, when there is perforation, to keep the balloon inflated for a long time, there is some special type of balloon which can allows the flow from the inflated segment. So these two are the things we need to consider. Thank you for the very lively discussion to all the and speakers as well. So it is very late at night, but still we are enjoying. Thank you so much.
Thank you, Dr. Khaled Jaman bhai. Dr. Khaled Jaman, do you hear me? Are you okay to say something? Khaled bhai, do you hear me?
Give him some rest. Give him some rest.
Yeah.
Mohsin, give him some rest.
He's last 2.5 hours with us. He's 3 hours with us, Dr. Khaled Jaman. Yeah. Thank you, Khaled bhai. I think Dr. Professor Chowdhury Meskat Ahmed, sir, your last comment from you, then good Wadud. Yeah.
I do not have any comment, but I have a little question to Dr. Saidul. They are using the ICRA catheter. I think it is pretty useful for right coronary artery cannulation. What is your experience?
Yeah, I just wanted to tell about the catheters, even some terms, but that session has been, I have lost that session. The Ikari, I was telling that because Dr. Ashut was telling that it's not that much helpful. I differ a little bit because I use it. I use it sometimes, and Ikari, and as I am a slender to some extent slender, like I love 5 French gate catheter. So 5 French Ikari gate catheter is really very beautiful for RCA, especially, and even 5 French left, Ikari left or Ikari right, whatever, you can use it, and it's really user friendly if you really can rotate it properly. The most important thing is that for the catheter, all the things what you are telling, everybody is telling. That's the most important thing is the spiritual one. That the one is that if you there is clockwise, counterclockwise, to remember those things, forget about those things. Just follow the instinct, and like driving a car with your basic instinct. Like this way, the catheter should be engaged, and then it will be properly engaged. And Ikari is really beautiful.
May I comment?
Thank you.
There is the engagement is very good, but support is not so much.
No. Ikari has got a very beautiful support in the RCA. No. RCA has got to be, because Ikari has a long beak, so the support will be very good there, especially with the 5 French gate catheter. If it is 5 French, because you can rotate it and you can really deeply, you can intubate it deeply. But if you take 6 French, for any 6 French gate catheter through transradial approach, I'm very much skeptical to go for an active backup support. The two terms, the passive backup support and active backup support. For passive backup support, 6 French is very good. But for active backup support, when you need desperately, 6 French is not at all a very good catheter to give you, because that one may harm sometimes. So for active backup support, we should not try that much for an active backup support with a 6 French or a 7 French gate catheter. I think so.
Okay.
But for 5 French, Ikari is good.
I think for support, it is no harm to use a double wire, especially 6 French catheter. Take 2 wire, one O, one N, and the beautiful. You don't need to think about displacement of the for both right and left. But it should be 6 French.
You're talking about body wiring, right?
Yeah. It also helps in different way. Even it can act as a cutting part at low pressure. 5 atmosphere it will. Otherwise, in non-common, it may need to 10, 15. But in a bit low pressure, you can give less barotrauma if you use the 2 wire. Moreover, it can give very good support.
Thank you
even
so much.
Even the jailing wire is helping you to cut the calcium a little bit also while dilating with 1 wire.
That's
the most important thing.
There is one more. There's the modified balloon angioplasty.
Yeah.
That is now is coming up. There is almost substituting the rota function. And it is nowadays it is my common practice. Use 2 wire and non-compliant balloon go up to 24 atmosphere. I prepare everything for rota, but came out without rota by modifying this technique. There is a good practice.
Thank you, sir. Thank you, sir. We have to stop because we have.
Sure. I have not even taken my dinner.
Thank you, sir. Everybody, thank you, Professor Mohsin, sir, being with us 2.5 hours, and also other expert panelists here. And our before conclusion, Dr. Wadud, sir, I will just announcement next series on 6th series, I think, on 12th November, Thursday at the same time with Dr. Kaisar Nasrullah Khan, that is wire technology and selection of wire, and also Dr. Tamjid Ahmed, Professor Tamjid Ahmed will talk on stent, using of stent and technology. That is most important topics, wire and stent. And I requesting Professor Abdul, please complete the session and your comments.
We have had a very long session, but I think every one of us has enjoyed the session. The 2 speakers have done very well in pointing out the different facts and important factors that we should be paying attention to. And the discussion is as lively as it can be. And everybody is pitching in and putting their, sharing their experiences. And some of the weird experiences that we have had, learn from Professor Momin Bhai and others, it actually helps. And always remember that you should learn to go beyond the books, the guidelines. Think for yourself, but be logical and be always pay attention to the patient safety. And you can be innovative. There's no problem in that. And you don't have to be always following the traditional guidelines and anything. Just make things happen and make things happen safely. If you have good idea what we are talking about, these lectures will help you to put you in a solid ground, and then you can innovate. As Professor Momin Bhai has shown, when he was in trouble, his brain started working overzealously and find out the solution. He later find out he has done the right thing. All of you, the youngsters, we could be the next Momin Jamal and be like him. That these lectures are for you with that end, with that aim. And thank you again, the panelists, the expert lecturers, speakers, and everyone. Thank you. Thank you, sir.
I missed 2%, Dr. Waliul Islam. Excellent talk. Dr. Timir Paul, we have brilliant presentation. Thank you to both speakers. And also Beximco Pharma.
Yes.
They are doing last 5 months with us at the midnight. They with us. Extra job in the morning time office and at the midnight with Beximco personnel. Thank you, Beximco. Thank you.
Good night, sir.
Assalamu alaikum.
Assalamu alaikum, sir.
Saibir bhai, assalamu
Waalaikum
alaikum.
Good night, sir.
Good night, sir.
Arif, thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, Wali, sir.
Thank you, Mohsin. Thank you, Mohsin. And Wadud.
অমলসা কি কোনো জ্বর নাকি?
জ্বর না, এমনি অসুস্থ, একটু অ্যানোরেক্সিয়া এন্ড ওয়েট লস
লাগছে, গ্লুমি লাগছে।
স্যার একটু সিক লাগছে।
হ্যাঁ, ভালো লাগে।
সাবধানে থাকেন মামুনদা, সাবধানে।
করোনা বাড়ছে কিন্তু।
জি স্যার, করোনা বাড়ছে, সাবধানে থাকতে হবে।
মহসিন পড়াশোনার নেশায় ফেলে কিন্তু আমার ঘুম টুম কমায় ফেলতেছে।
থ্যাংক ইউ। আপনাকে কিন্তু একটা টক দিব নেক্সট, রেডি থাকেন
ইনশাআল্লাহ।
বেঁচে থাকলে। ওকে
স্যার, গুড নাইট স্যার।
হ্যাঁ, থ্যাংক ইউ।
স্মার্ট প্রেজেন্টেশন ওয়ালি ভাই।
Thank you and good night.
ওয়ালি ভাই অনেক সবসময় সুইট।
থ্যাংক ইউ।
আজকে সেলফি তুলুন, সেলফি।
অসংখ্য ভালো থাকেন।